Hi, this is Tom from Simon Medical again. We've already brought the NIM into the room. We've got the appropriate supplies. We've got the NIM set up away from the cautery unit. So let's discuss how to set it up, how to hook up the patient, how to set it up appropriately for the case you're doing, how to utilize it, and then maybe how to troubleshoot some items that may come up occasionally. So what I'm going to do, I'm going to show you how to start a case. I'm going to go to select quick setup. Now, another way to do this is just to turn the machine on once the patient's hooked up, but I already have the machine turned on just to bypass the boot up. So we're going to go to a parotidectomy, and we're going to press select. Okay, so we've got a 2-channel parotidectomy. I'm going to press EMG. I'm going to turn the volume down a little bit, just a little bit, so I can hear myself talk. With the placement of the electrodes, and in this case with the parotid, we've got abicularis oris and abicularis oculi. So we're going to have electrodes in the eyes and near the mouth. That is pertinent. The placement of those is pertinent to the outcome of the case. So that truly is a physician task that should be completed, not necessarily a circulator task or any ancillary OR staff. Once we've got this screen and we know the electrodes are working, we are going to do an electrode check. Okay, so if you notice the tab at the top that goes left to right, I'm going to touch electrodes, and these are impedance numbers. So we've got 2 channels. Those numbers should be less than 1. These are less than 1, so they're 0.6. So if your numbers are higher than 1, and again, this is an older system, the newer system gives you check marks, you know you need to check the placement of those electrodes. You either need to check in the patient interface box, or you need to check and make sure an electrode does not come loose in the patient. Okay, so we're good here. We know that. If we want to go to settings, what we can do, let's say we want to do something outside of the default, and I'm not suggesting you change any of the defaults. The defaults are, for 95% of cases, the default settings are appropriate for what the surgeon wants to do. And it's in those guidelines that Medtronic felt were appropriate as well. But if you do want to change things, I want to show you what the normal sounds are first, okay? So during the case, as it's going to take a while, obviously, to expose the nerve and get where the surgeon thinks the nerve may be. So when we get to that point, they're going to stimulate, and what I'm using is a patient simulator. So this would technically be the patient's side of the patient's face that we're stimulating here, but we're stimulating a box. Okay, so if there was a stimulation and it did not get an EMG response, we would hear that sound. And I'm going to turn that up a little bit so that you can hear it. Okay, that's what I call the Tweety bird. So that means the stimulus delivered, the probe works, it delivered the milliamperage, but it did not get enough and generate an action potential in that nerve to set off the electrode that's in that muscle. Okay, now on the other hand, if you did get a positive response, this is what you're going to hear. And I'm going to turn this up a little bit. You can hear a banging. So that's a response. That's a nerve response. Again, not a nerve response, an EMG response. That banging is the EMG response. So they can be fairly confident that that's stimulating the nerve that they're looking for. In a parotidectomy, that would primarily be the facial nerve or branch of the facial nerve. There are some other settings on here. If I want to turn up the volumes for the tone, let's say I want to hear that response louder, I can go in here, and I probably would on this machine. It's turned down a little low. So I'm going to go back. I just turned up that volume so we can hear that positive response a little louder. And let's see what happens now. Okay. That's a little bit louder. But what I'm saying is you can adjust those. And normally the default's fine. But I want you to know what those settings are. It's not something you'll need to change frequently. Okay, patient. Now you can save patient name before you start the case if you want to save the patient name so that it's on the screen. It's not done very often, but sometimes if you want to save a picture of it or you want to save a screenshot, you will put the patient's name in. It doesn't mandate that you do that, but you certainly can do that if you want. Let's say we're in a case and we actually set it up wrong. We're in a thyroid and we set it up as a parotidectomy. We're like, oops, it's still working because you still got 2 electrodes. It's just the electrodes are monitored wrong. You could go to select quick setup and go back to, oops, that was supposed to be a thyroid. And I defaulted it to parotid, and then you would select. So you can do that during the case. Realistically, you're still monitoring that channel. It's just labeled differently. So you're still monitoring. So don't panic. There are some ways to customize it. I'm not going to go into that now because it's in depth. If a doctor wants certain settings with the event threshold higher, the stimulus higher, there's certain ways to do that. We can certainly try to help you at Simon Medical if that's something you need to do. Really troubleshooting. So a couple things. You stimulate and you don't get anything, okay? In the electrode, in the probe kit, or the electrode kit, there's a stimulus return. The stimulus return and the ground have to be placed in the patient as well. So if you don't put the stimulus return in, the probe won't work. So you've got to look at all the electrodes in that, and you've got to look at the user guide with the machine to see. There's a white wire and a green wire that go into the sternum. And the way I used to do it, to remember, and it's not an exact science. If you forget you can't reach the sternum, you can put them in the shoulder. But the way I used to remember is because I live near White Sox Park, I would remember White Sox, green thumb. So the white electrode would go towards the foot and the green would go up towards the thumb. That's me. Now, if you're in Boston, that's going to throw your whole thing up. But that's how I used to remember it. So if you want to remember that, feel free. If you're getting a lot of artifact, okay, and especially when electrocautery is going off, make sure your muting cable did not come loose. Okay, the muting cable is number one. You'll get all sorts of noise whenever electrocautery goes off. So have those cords, both of those cords, the bipolar and the monopolar, wrapped around this and have it close to the electrocautery box itself. And that will mute the NIM. You won't be monitoring, you're not monitoring any nerves during bipolar cautery. So if you're using bipolar cautery and you hit a nerve, you're not monitoring it. So that's just the nature of the technology with nerve monitoring. If you're getting a lot of artifact, you're just getting a lot of beeping on all channels, there's a good chance that the patient's getting light. And this is always a touchy subject with anesthesia because they'll say, no, they're not getting light. And then a few minutes later, maybe you see them cranking the dials. And if patient gets light, it means they're moving and twitching a little bit. That's setting off the nerve monitor. So that's very common to do that and ask if the patient's getting light. If you're stimulating and you're getting that stimulation noise, the Tweety Bird noise, and you're positive you're on a nerve, it is possible that you may want to check, and this is something to proactively address with anesthesia, is that long-term paralytic should not be used with nerve monitoring. And I guess that's pretty common knowledge, but it's worth mentioning at the beginning of the case. So using a short-term paralytic during intubation, like succinylcholine or sucks, as they say, is fine. It's out of the system very quickly by the time you're trying to stimulate. But long-term depolarizing paralytics will render the NIM null and void, basically. So that is always worth a conversation, or just a quick reminder to anesthesia at the beginning of the case. So that's really it. Sometimes you'll get, especially if you're doing on thyroid, and you're retracting and you're touching the trachea, we've got those electrodes that are near the vocal folds, and you're banging with retractors. That's going to cause noise. That's just going to cause movement of those muscles. And you're going to get a lot of, manipulative artifact. So that's pretty common in itself. And that can be common in a parotid pulling. You're moving the nerve when you're retracting. So those are the most common things that I've seen. Not to say something else weird can't happen, because it can, but those are the most common things. So I hope you appreciate the information. It can be brief. If you need anything more specific, or your customer, contact us at Simon Medical, and we'll see if we can help. And I thank you for your time, and we look forward to continuing this series.